Welcome to Advanced Perspectives in MS, a virtual journal club series for the advanced practice multiple sclerosis clinician. At this time, all participants are in listen-only mode. If anyone should require operator assistance, please press *0 on your telephone keypad. A question and answer session will follow the formal presentation. You may ask a question at any time by typing it into the Ask a Question feature on the left side of your screen. It's now my pleasure to introduce your host, Brian Walker. Please go ahead, Brian.
Thank you, Kevin. Thanks for the introduction. I greatly appreciate it. And thank you, everybody, for joining in. We greatly appreciate having you here. This is another one of our journal clubs, virtual journal clubs, our little fireside chats, if you will. I am thrilled to have, again, my co-host, John Kramer, who will be manning the text box and the question box, and we'll be pausing every once in a while. John will throw in a couple of questions as we move along to try to make this as conversational as possible, although we know that's a little bit challenging in the virtual domain, but we'll try our best. And John will feel free to interrupt me at any time if questions pop up, or if there are comments that he would like to make, and we'll move through this. This is actually our last in this series of virtual journal clubs, and I guess you could say that we were a little bit ahead of the curve. We started this off pre-COVID era, and we thought that this would be a great way to get folks together to talk about a particular article, dissect it a little bit, use that as a springboard to talk about other topics and related topics around MS. We want to be as inclusive as possible, so we certainly welcome all provider types into the mix, so we can have a very robust and interprofessional and interdisciplinary conversation. We certainly would really like to thank CMSC for running with this idea that we had and making it a reality, and certainly we couldn't have done that without our supporters for this lecture series, to include the Celgene Corporation, EMD Serono, Genentech, and Mallinckrodt. So we certainly are thankful for everybody to support us, and certainly all of the folks who log on a Wednesday evening with their very, very busy schedules. And so hopefully you'll be able to see our slides, and certainly if you're having technical difficulty or we're not coming through either via audio or through the slides, please let us know, so we can try to correct that as soon as possible. Again, I'm Brian Walker. I'm a PA here in Durham, North Carolina at Duke University. I'm in the Division of MS and Neuroimmunology. Here are my disclosures, and again, I'm very happy and privileged to be joined by John Kramer out in Nashville, Tennessee, and there's John's disclosures as well. Our session objectives and accreditation for this evening, we're doing a topic tonight on monoclonal antibodies and their use in patients living with MS and NMOSD during pregnancy and or lactation. So hopefully we'll have a little bit more of an understanding about what the current landscape is right now within these two disease states. But we're also going to talk just a smidge about what our colleagues in rheumatology and gastroenterology are doing with some of the same biologics that we use for these disorders as well. Again, CMSC is great in being able to provide all of us continuing education credit. So at the completion of the program this evening, within the next day or so, you'll get an email from Tina at CMSC, who's been fantastic and helping John and I navigate through all of this, and she'll be giving you directions on how to claim your CME credit. And we'd like to give a big shout out to Tina to say thank you very much for all the help that she's extended to us, and certainly putting up with us as well as we navigate through this series. So again, today, what article we're going to discuss is titled Monoclonal Antibody Treatment During Pregnancy and or Lactation in Women with MS or Neuromyelitis Optica Spectrum Disorder. And that was recently published in Neurology, Neuroimmunology, and Neuroinflammation. And what we wanted to do is just sort of frame up a background. We were chatting a little bit before the program started about the fact that it seems that for whatever reason right now, I personally have been having a lot of conversations with folks around pregnancy planning, what to do both with multiple sclerosis and neuromyelitis optica spectrum disorder. And they have some shared similarities, but they have some differences as well, and certainly that translates to the medications that we use. And it's an important conversation when we start to frame up, who gets these disorders, and we all know this, but just sort of to frame everybody's mind in this conversation over the next 50 minutes or so. We know that MS is more common in females compared to males with about a 3-to-1 ratio. It's most commonly diagnosed between the ages of 20 and 40. And there's a decrease in the relapse rate during pregnancy, but a trend upwards postpartum. And then with NMOSD, it's a little bit different in that in some respects the epidemiology is such that in females it's more common than males, and it depends on the cohort study that you read. It could be anywhere from 3-to-1 to 4-to-1 to multiple times that, 15-to-1 or 20-to-1, depending on the cohort study that you look at. And about half of all of those patients are under the age of 40. So we're talking about females of reproductive age, and they're usually in the prime of starting their careers and starting their lives and maybe starting families, and they're having to navigate all of this and try to think about what's going to happen with their diseases. We also know that NMO behaves a little bit differently in pregnancy than MS does. We sort of fall back a little bit on a thought process that MS has a little bit of a protective mechanism from pregnancy, but we're also concerned that pregnancy could actually exacerbate NMOSD a bit in some patients, and we worry about that, and we certainly worry about a more devastating relapse in an NMOSD patient who might have been very, very active pre-pregnancy. So all of these factors we have to take into consideration. We have to take into consideration if the patient had a prior pregnancy and if they had a diagnosis prior to their prior pregnancy, and what did that pregnancy yield, and how did that go. I'm sure that most of us on the call this evening have had patients that had their initial diagnosis during pregnancy or immediately after pregnancy when something was not right, and they went in for further evaluation, and the diagnosis was made at that time. So, that just sort of frames up the conversation. And we also know that we have this expanded armamentarium, if you will, of disease-modifying therapies that are more highly efficacious than some of the older platform medications that were injectables. And, they have their risks as well as their benefits. And the biologics are certainly excellent medications, not only from an efficacy standpoint, but also from a safety standpoint. These are medications that we will routinely use these days in patients, and not just after they've maybe tried and failed a couple of other medications, but first out of the gate therapies for patients who might be a little bit more active in their disease course. So as we start to step into this article itself, there are going to be some things that I'm going to point out along the way that are specific to this particular study, and how we should just view this particular study as it is, and what the data is, and try to extrapolate some meaning from it, but know that it is a very specific patient set. So this is a prospective cohort from the German Multiple Sclerosis and Pregnancy Registry. And in particular, they had looked at patients with exposure to a monoclonal antibody during lactation. So this is a very, very defined cohort. The inclusion criteria were that they had to have had exposure to a monoclonal antibody during lactation, that they had a live birth, that breastfeeding while on the monoclonal antibody could be met by a couple of different definitions. One is that they were breastfeeding for at least 1 day after their first postpartum infusion, and if a monoclonal antibody infusion was delivered during pregnancy and that was administered within 100 days of delivery for natalizumab and 130 days for ocrelizumab, the infants were considered to be exposed during breastfeeding from the first day of life. So we're going to separate these subjects into a couple of different cohorts because some of these folks actually received their monoclonal antibody therapy during pregnancy. Some did not. Some restarted it after delivery and decided to start it while they were breastfeeding. They did perform telephone administrative questionnaires completed by the mother during pregnancy and at 1, 3, 6, and 12 months postpartum. For a very, very small group of subjects, they were able to analyze natalizumab concentration in breast milk and natalizumab serum concentrations in 2 of the subjects and their breastfed infants. So that gives us some very specific and distinct objective information, which is great, but it's very limited, but we'll talk about that a little bit further on down the road. So in this database that they have, there were greater than 2,000 pregnancies within the database. Out of those, 23 had exposure to a monoclonal antibody during lactation. 17 out of those 23 were for natalizumab, and 6 of them were for an anti-CD20 medication. And then they stratified those out to 3 being rituximab, 2 being ocrelizumab, and 1 having exposure both to rituximab and ocrelizumab because, hey, why not? Out of those, 13 were exposed to natalizumab during the 3rd trimester. And out of those larger group of patients, 1 was exposed to ocrelizumab during pregnancy. So that sort of gives you the landscape of the demographics. Now, I want to dive in a little bit deeper to the clinical characteristics of the mothers. This is a busy slide, and there's a lot on here, so I want to unpack it all because I think that there's some really good information here. What they were able to do is get a very sort of tight group of patients that they were very specific for, and when you're designing a study, this is a really good way to identify a good set of population for which to do your study with. So for the diagnoses out of the 23, 21 out of the 23 were diagnosed with multiple sclerosis and 2 were diagnosed with neuromyelitis optica spectrum disorder. So not a lot of NMO-SD patients, but more MS patients. When you look at the age at conception, the mean age was 34, and the BMI at conception was 24.48. So obviously non-US. And I want to comment on that at a few different points along the way here. Disease duration at conception, the mean was 9.22 years. So they've had the disease for quite some time now. Their EDSS before pregnancy, the median was 2.5, so not too bad. But if you look at the range, it ranged from 0 to 6.5. That's a big range, and I think that we could all sort of agree there's probably not too much difference between a 0 and a 2.5. You got a little bit of wiggle room in there, but there's a big difference between a 2.5 and a 6.5. So the median was a 2.5, and I think that's also important for us to look at. Now, the number of disease-modifying therapies that they were exposed to prior to their current monoclonal antibody therapy was a median of 1, but again, that range was 0 to 6. So a fair amount of variability in there with the number of disease modifiers that they were exposed to before their current monoclonal antibody. Now, what I liked here is they looked at sort of a barometer of how active their disease was going into this. The number of women with greater than one relapse in the year prior to pregnancy, the absolute number was 10. That's a pretty fair number if you think about it. So out of 23, that's 43% of them. So that's not an insignificant number. When you look at the number of women with one or more relapse during pregnancy, that was 4. So maybe a little bit more than I would have thought, but still, it's a decent number to take a look at. Here's the other one that I thought was interesting. The start of monoclonal antibody postpartum in the number of days. The median was 19. So, yeah, okay. I mean, that sort of makes sense to me. I have 2 kids, and when my wife and I had both of them, it was just a complete blur, probably for the first several months when they were born, and we sort of had this mantra where we would say, after delivery, it was just 48 hours, get me to 48 hours, and once we got to 48 hours, it was get me to the first week, and once we got to the first week, it was get me to 2 weeks, and then 1 month, and then 6 weeks, and so forth. And it sort of built. And so, thankfully, everybody was healthy with both of our pregnancies, and that went well. But I really couldn't imagine having that extra layer of complexity when you're thinking about having to think about either MS or NMOSD, and when you would need to restart along with everything else that you're doing. So, I think 19 days as far as a median is good, but if you look at that range of anywhere from 1 to 194, I could say, yeah, well, that's probably within the range of expectation. So duration of exposed breastfeeding for these moms and their babies in the number of months was 6.1, again with a fairly wide range, going anywhere from 0.3, so just shy of a month, all the way up to almost 2 years. So again, that's a pretty big range that's there. So that's a lot of information on that slide, but I really think that it was important for us to unpack that, because I think it's going to be valuable for us to look at the results as we start to dive into those a little bit more. So with regard to the pregnancy outcomes, generally it looked pretty darn good. There were only 4 preterm pregnancies, so that represented only 17%. And we're going to take a look at the comparison to the sort of expected, what's expected in that age-matched population in Germany. So 4 preterms, 2 of the 4 were exposed to natalizumab during pregnancy. One of those was secondary to an incompetent cervix. The other one was a planned C-section due to increased LFTs, but without signs of HELLP syndrome. So the LFTs were trending up, but no other signs of HELLP syndrome there. Of the other 2 who were preterm but were not exposed to natalizumab during pregnancy, one was due to a placental insufficiency, and one was premature rupture of membranes from an incompetent cervix. So when you start to look at who they were comparing these to, they were compared to age and sex-specific values obtained from the general German pediatric population, excluding preterm births. And so, again, they sort of stratified it out to natalizumab exposure in the 3rd trimester or only during breastfeeding. So we're going to break down those results a little bit and talk about those differences there. The different measures that they looked at were the aforementioned prematurity, birth weight, by gender, need for antibiotics, need for hospitalization, or developmental delay. So here's the punchline, or at least one of the punchlines here. And that was that there was no signal of harmful clinical or biological effects attributed to breast milk exposure. Okay, so that's very specific. So nothing attributable to breast milk exposure. So that's one of the key takeaways, and we're going to circle back on that with some of the data a few slides in. However, infants exposed to natalizumab during the third trimester had a lower birth weight and were hospitalized more often during their first year of life. And this is consistent with some of the other pregnancy natalizumab exposure studies and data that have been presented in the past. Again, there's been a fair amount of data that's come out of Europe with regard to this, and it's pretty darn consistent. So when you look at that data that's specific to MS and you look at some of the other data in the literature with regard to natalizumab exposure during pregnancy for, say, inflammatory bowel disease, it's very, very similar. So I think we're fairly comfortable with the fact that natalizumab exposure in the third trimester does not portend very good outcomes. Now, here's that sort of breakdown, and I apologize for some of the smaller numbers here, but we'll try to go through this. And I just want to just stop here for 1 second and just check in with John. John, did you have any other particular comments up until this point, or had you received any questions or comments up until this point?
No questions yet, Brian. This is great, and I think, to your point, there's been clear case reported evidence before with natalizumab use, particularly in during pregnancy, leading to various hematological abnormalities and low birth weight. So I think that that one particular case is consistent with what we've seen in the literature before.
Yeah, absolutely. And we're going to take a look a little bit about those hematologic issues with that third trimester exposure to natalizumab in a few slides. And so when we looked at, or when they looked at, the authors looked at the numbers of observed adverse outcomes in the cohorts versus expected, and again, that's that general registry of live births in Germany. Then we're looking at the outcomes on that far left column, so those are the outcomes that they measured. That next column is the expected, so that's that sort of quote-unquote control group, if you will. The next couple of columns are a little bit funky, so let me go through those. The next column over is third trimester natalizumab exposure for all infants. The next one is third trimester natalizumab exposure where they have greater than 12 months of follow-up on those patients. The next column over is no third trimester monoclonal antibody exposure at all on all infants. And then that final column is no third trimester monoclonal antibody exposure where they had greater than 12 months of follow-up. And so again, when you looked at the numbers for prematurity, it was higher in those that had exposure to natalizumab in the third trimester. When you looked at birth weight for males, the birth weight for those who were exposed to natalizumab in the third trimester was a bit lower than that expected, but not really that different than those who did not have exposure to a monoclonal antibody in the third trimester. And the same thing for girls. There was no really significant difference in birth weight there. But then the other signals that we had started to talk about with regard to antibiotic treatment. So greater than one antibiotic treatment within that first year for males and for females. For the males was a little bit higher than the expected. in the third trimester, natalizumab-exposed infants, and the same rang true for hospitalizations. Greater than one or more hospitalizations for both males and females with regard to the expected transition of exposure to natalizumab in the third trimester. But then you look at that last row there for developmental delay, and there really was no developmental delay that was found, again, in this cohort of 23 subjects compared to what's generally seen in this similar population in Germany. So at least that was encouraging. And so if you looked at some of the other outcomes, when you look at chronic disease, one was diagnosed with pediatric asthma, and I found this interesting. One was diagnosed with a hazelnut allergy. I guess that's considered a chronic disease in Germany since Nutella reigns in Germany, and everybody puts Nutella on everything. My mother-in-law was German, and we had the opportunity to go over there a few times to visit my wife's extended family over there. And man, I fell in love with Nutella, and our kids love it too. So I'd hate to have a Nutella allergy and be in Germany. One infant did have slight generalized muscular hypotonia due to perinatal asphyxia, but at 6 months, the medical exam, the neurological exam, was quote-unquote satisfactory, whatever that meant. And in that infant, they had been exposed to natalizumab throughout pregnancy. But again, there were no developmental delays seen in any of the 23 infants that were born. Now, to John's point, what were some of the hematologic abnormalities that were seen, and they were seen again with the natalizumab-exposed infants during the third trimester, of which again there were 13 of them. Now they had data to include a CBC obtained at birth in 12 out of the 13, and then they were able to obtain a CBC during breastfeeding in 7 of them. So 5 had mild to moderate anemia and or a mild thrombocytopenia at birth, but 2 had mild to moderate hematologic abnormality during breastfeeding. So again, not huge numbers, but there certainly is something that we could see as a signal with regard to some of these abnormalities with the natalizumab-exposed infants during the third trimester. John, I know that you had looked at this as well. Was there anything else particular that you wanted to add here?
No, I don't think so, Brian. A question did come in right after you'd asked if a question came in from Margaret Burnett, and the question was about were the women on monoclonal antibodies prior to pregnancy, and I can take this one. So the authors only mentioned that of the 4 women that had postpartum relapses, 2 of them had been exposed to monoclonal antibodies prior to pregnancy. They don't state which monoclonal antibodies those were.
Yeah, that's correct. Thanks, John. And I wasn't able to fit every single data point. That's a great question. And certainly you have access to the article as well. So certainly go back in. They did mention that, but as John stated, they didn't specify which ones per which subject. So great question. Keep those questions coming in. So next, what they looked at was with respect to B cells. So exposure to monoclonal antibodies during breastfeeding, but not in the third trimester. There were 10 altogether that they were able to get the results on. 4 were natalizumab exposure, and the B cells were normal in 2 out of the 4 that they were able to obtain. 3 were rituximab, 2 were ocrelizumab, and then there was that 1 that had exposure to both rituximab and ocrelizumab. And 5 exposed to the B-cell depleting monoclonal antibodies during breastfeeding had normal B cells. So even though they were exposed to a B-cell depleting monoclonal antibody, 5 of them that they were able to collect the data on had normal B cells. 1 who was exposed to ocrelizumab in the 2nd trimester had decreased B cells at birth, but they normalized at 79 days postpartum. And then 1 who was exposed to rituximab 16 months before the data delivery, which is quite a long time, as we know, had decreased B cells at birth but normalized at 93 days postpartum. So I think this kind of goes along with some other data that has been collected with regard to exposure to anti-CD20 monoclonal antibodies and the rates of B cell immediately upon delivery and then normalization postpartum for a time period afterwards. So again, very small numbers, but tends to be consistent with what we're looking at as far as the other studies that have been performed. So when we look at natalizumab in breast milk, they were able to capture quantifiable levels of natalizumab in breast milk, but they were very, very low. And when you look at any medication in its relationship to breast milk, they use a measure called the relative infant dose. So this is to assess exposure of a drug via breast milk. And they do this by dividing the absolute infant dose, which is the concentration of breast milk multiplied by the daily intake, and they have a little formula there, and divide that by the maternal dose, and it gives you this relative infant dose. And generally speaking, for most medications, an RID less than 10% is considered probably safe for a healthy child. So no other underlying medical conditions with baby. If that RID is less than 10%, it's considered probably safe. And the author's analysis for the levels that they were able to measure for those on natalizumab during breastfeeding, where they were able to get the samples, was far below that 10% at 0.5%. So all in all, some pretty good data, but you know, what do some other folks think about this, and where are some other areas that use the lower, the monoclonal antibodies in different disease states, and 2, 3 different articles came out, again, very recently, within the past year or 2, that looked at this. One was inflammatory bowel disease and pregnancy clinical care pathway. This was a inflammatory bowel disease parenthood project work group. This was published in Inflammatory Bowel Disease just last year in 2019. And you know, just to sort of frame up for those of us who don't deal a lot with inflammatory bowel disease, it affects 0.5% of the U.S. population. About half are female, and similarly with MS and NMOSD, most are diagnosed in their reproductive years, and they do utilize monoclonal antibodies, including natalizumab. Now, in this work group, and again, they did a very deep dive and a lit review of natalizumab and these other monoclonal antibodies for inflammatory bowel disease. their ultimate recommendation was for continued use of natalizumab, but an altered dosing scheme during pregnancy, and they recommended resumption of natalizumab postpartum while breastfeeding. And so it kind of depends on which study you read and who you're reading, but this was a fairly large work group that was trying to come up with a consensus statement. And you know, we were joking before that anytime folks come up with a consensus statement, they spend several months, and there are many people on board, and you go through like 5 or 6 pages of how you went through the analysis and what you analyzed, and then you have one paragraph that basically sums it up by saying, well, maybe, kind of, sort of, and we need more data. And so they're not very clear about what their recommendations are. But there's a pretty strong recommendation here, and in a couple of other articles that I was able to look at when going through this. And one of them was from another German group. This was also a consensus report. This was from the Austrian Societies of Gastroenterology, Hepatology, Rheumatology, and Rehabilitation, which is kind of an odd combination, but I guess they're all one big group. And they did a review of the rituximab Global Drug Safety Database. And so their recommendations were different with regard to rituximab. They felt that it should be avoided in pregnancy for rheumatologic and gastroenterologic issues. It should be avoided in pregnancy, but it might be acceptable prior to conception or in the first trimester. And they said breastfeeding was not recommended. However, when you dig into that article a little bit deeper and you looked at the patient population that they were analyzing, about half of those patients were treated with concomitant cytotoxic medications, in addition to the monoclonal antibodies, which could skew the data regarding poor fetal outcomes. So I don't know that that was necessarily a clean data set. So, you know, the study that we're reviewing here tonight has lower numbers, but it's a pretty clean data set. So one of the other guideline consensus statements, again, this year, 2020, was from the American College of Rheumatology, and it was for the guideline for the management of reproductive health in rheumatologic and musculoskeletal diseases. What they came down with is they said they conditionally recommend rituximab at conception and during pregnancy, and they strongly recommended rituximab during breastfeeding. So again, you sort of see a little bit of difference with these consensus statements, but you know they're actually making some valid points, I think, and it's a lot to do with where they're getting the information and how they're analyzing it. You know, the other study was again a pretty good sized European cohort. These others were more U.S. cohorts. So taking a look at this data in aggregate, we'll try to help us make more informed decisions and help our patients make more informed decisions. And I think that would be a good thing. One resource that's out there that I wanted to draw everyone's attention to, if you haven't seen this before, and if you don't utilize this resource, LactMed at NIH is a service that is continually updated and reviewed through the NIH, and it just deals with medications in lactation. And so when you take a look at the information on rituximab, ocrelizumab, and natalizumab on LactMed, you know, they're not really going to make recommendations as to, yeah, you can use this, or no, you can't. That's not really the gist of the service, although they do reference these consensus statements and the most updated data. But what they do is they basically look at the pharmacokinetics of the different medications and how that translates into breast milk. So for rituximab and ocrelizumab and natalizumab, they found very low concentrations of all three in breast milk, and they feel that it's generally safe to use during breastfeeding because the molecules are fairly large and they're likely destroyed in the infant's GI tract due to its molecular weight. So not much is actually going to be transferred to baby, and certainly the benefits for breastfeeding are significant, both in the short and long term for the infant, and we try to recommend that as much as we can. So again, I just wanted to highlight the LactMed service at NIH. I included the link here, but certainly it's as easy for you to type in LactMed into your browser and it'll take you directly there. And again, that's for a large number of medications, and it's very helpful when you're trying to figure out things for other disorders, migraine and so on and so forth, that we treat concomitantly with our MS and NMOSD patients as well. So it's a great resource for you. Okay, so I've got this last slide that I want to put up here, and these are some of the study limitations that I thought of, and some of the thoughts for further discussion. And so I want to put these out there, and then certainly we'll pause and take a look at some of the questions that have come in, and maybe we can generate some additional conversation around these discussion points. But, you know, again, there were small numbers in the study. This is not a lot. And so you'd like to see large cohorts, lots of good data, lots of verifiable data. I think they did a good job in how they designed it. It would have been great if they could have executed this with a larger number of patients and infants. But, you know, you have what you have, and you're working with what you have to work for. And I think, you know, there's confounding variables of the late-term exposure, right? So I think it's great that they added in the information around the third trimester exposure to natalizumab, and I think it would be important for us to take a look at that and continue to take a look at that. And I think there's sort of these two separate issues that are certainly related, and that is the use of these medications during pregnancy and the use of these medications postpartum during breastfeeding. And again, I think you have a little bit of a nuanced difference there between MS and NMOSD. But I think, you know, if we could try to take a look at these two separately as well, that would be helpful. The other is that this cohort again was within Germany, and they have a nationalized healthcare or a unified healthcare system. So they have very specific guidelines for prenatal care, for pregnancy care, and for postpartum care that is significantly different than the United States. So what would the data in the U.S. look like? So again, this is I think a well thought out study and a well executed study, but this is a fairly isolated patient population, and what would this look like here in the U.S.? And then again, looking at you know, early versus late pregnancy exposure to monoclonals, again that late term exposure. And it would be great to have the additional breast milk analysis for both ocrelizumab and rituximab in addition to natalizumab. And again, it would be great to have that additional breast milk to serum comparison data. That would be ideal. But would that study design be ethical based on pediatric risk categorization? So I serve on the IRB here. And we are always having big debates over what ped risk category a study is when it's involving minors, and you know what is that going to do, and how difficult would that be to get when we're taking a look at the issues around blood sampling and milk sampling. I think that would be easy or easier for mom, but I'm not sure what that would be like for baby. And then, you know, one of the questions that we struggle with on a more practical basis and is that would the risk of untreated MS or NMOSD during pregnancy outweigh the theoretical risk of infant exposure to monoclonal antibody in breast milk? And so again, that gets you to the separation between exposure during breastfeeding and exposure during pregnancy. But I think that these are interesting questions that we still need to think about. So I'm going to pause here. We're at 8:47, so let's talk a little bit about these items. Let's hear from some of the folks who are out in the virtual world, some of the questions that have come in, and then we'll take it from there. John, what have we got here?
Sure. So a question came in about when were the natalizumab levels measured. And Brian, my reading of the paper said that women who had been exposed to natalizumab or anti-CD20 therapy were included. It was 1 to 100 days after administration for natalizumab and 1 to 150 days for anti-CD20. I don't think they gave a specific date for each patient in terms of their exposure to said drug and then the testing of the breast milk. Is that accurate?
Right. That's what I read. Mm-hmm. Yeah.
Mm-hmm. And a follow-up to that was made interesting about whether or not pump and dump for 2 days would have helped. And that brings up an interesting conversation. There was a separate paper published in NIH earlier this year, first author Crisco, where they looked at 9 patients exposed to rituximab. And they saw the same type of data, you know, RID of 0.33%. And so, you know, to your point, of course, we'd always like to see bigger numbers, but now you're talking about a cohort of, you know, 15 to 20 patients with exposure to rituximab, and you're seeing the basic same RID numbers here. So I think it's pretty reassuring that we're talking about probably single-digit milligram doses of exposure. And to the point Jordan made, Brian, I mean, a lot of this we likely believe is degraded in the gut anyway. That's why we don't administer anti-CD20 therapy orally to adults anyway. So,
right, absolutely, and I think, you know, what would be great is if you're thinking about this, you know, long term, you know, following these kids out, you know, as far as possible, right? It'd be great if you could look at them at 1 year, 2 year, 5 year, you know, 10 year, and if you know everything is looking fine, well then you've really proved your due diligence at that point. You know, some folks who are much more in tune to pediatric longitudinal studies would probably say, nah, it's probably overkill and you don't need that. But I mean, it would be great to have more longitudinal data on this as well.
Another question came in about the use of satralizumab for NMOSD during pregnancy or breastfeeding. And the reality is, of course, that there's no data as it relates to breastfeeding with this particular molecule. But generally speaking, subcutaneously administered medications have we call a high volume of distribution. And the higher the number is, the greater the spread through various tissue compartments is. And so lower numbers of volume and distribution seem to have higher plasma levels and therefore potentially higher risk of excretion into breast milk. So those volume of distribution numbers are almost always in every PI. I don't know the satralizumab one off the top of my head, but that's something that I've used before as guidance. Like warfarin's like 6 and teriflunomide's like 11. But for instance, interferon beta 1A, it's like 1,200. So you would expect you know, minimal excretion into breast milk.
Yeah, absolutely. I'm reading through some of these questions that came up here. I see our friend Amy Perrin-Ross asking about do we know what the altered dosing of natalizumab was in the GI study during pregnancy? And Amy, I do believe that they used an extended interval dosing scheme I don't think that they alter the concentration or the actual dose of the natalizumab per infusion. I do believe that it was extended interval dosing, but I'd be more than happy to send you that paper, and maybe we could dive into that as well.
The other thing, Brian, that I wanted to bring up too from that other paper I mentioned that was in NNI, the author suggested that by day 7 after exposure to rituximab, basically the concentrations in breast milk were near zero. So to the point that was made earlier about the question of pump and dump, could you, and I've had this conversation with women with anti-CD20 therapy that's administered IV, could you possibly just have enough breast milk stored, do pump and dump for 5 to 7 days, and then just go back to it? So it at least provide maybe another level or blanket of security, and allow people to then still be breastfeeding the baby and also optimizing their treatment for MS or MLC.
Right. Yeah, and that's a great point, and I think that there is a little bit of flexibility in there. If they are able to store up a little bit extra, that would be great. The reality is that not everybody is able to exclusively breastfeed. At some point in time, you're introducing formula and other things into the mix as baby gets older too, with respect to other food. So I think that there's a little bit of flexibility in there, and so I think that would maybe give us and mom a little bit more comfort level with regard to those decisions.
Brian, there's a question about the pediatric asthma and the hazelnut allergy. Was that the same patient, or were those two separate?
No, those are two separate babies. Yep.
Thanks.
Well, John, was there any other closing remarks that you wanted to make as we wrap this up? I want to be mindful of folks' time here on the East Coast. We're getting up to 9 o'clock. I know that we have folks from all over the country, and I appreciate that. And I want to give them back the gift of time if at all possible. But any additional closing remarks or thoughts about this study or about our series in general?
I would just say, first of all, that was a great presentation, and the more I read these small studies involving breast milk and various DMTs, I think it certainly helps us gain confidence. And as you and I were talking earlier, I think that historically we've been about 10 years behind rheumatology from a therapeutic intervention standpoint in many ways, and many of us are cautious by nature.
Right.
But this type of data to me really, I think, highlights the importance that there really does appear to be very low risk, if any risk, for women who are breastfeeding on these two particular monoclonal antibodies, if that is part of the discussion in terms of initiating drug therapy postpartum. So, if you go back to the PRIM study, we know that, of course, the risk of relapse is certainly higher in the first 3 to 6 months postpartum. And so I like many of you, I'm sure you worry about these patients, right? And we know that there is a potential protective effect just by the act of breastfeeding based on several smaller studies that have been published recently. But hopefully this will give us some more confidence that, based on, again, on this limited data, there appears to be minimal to no risk to the infant as it relates to breast milk exposure.
Yeah, and I think it's going to be important moving forward as we're seeing an expanded armamentarium of biologics that are being approved both for MS and for neuromyelitis spectrum disorder. Again, this is the patient population. The patient population is not really changing, although our toolbox is. I think it's going to be important for us to continue to take a look at these. And I think, at least in the beginning, we're going to be held to small cohorts, smaller studies, hopefully well thought out, well done. I think this was a well-designed study, even though that I had the small numbers. But I think we're going to be looking at some more of this type of data as we have these newer agents that come to market, and we're trying to navigate that again with this patient population. So let me just go ahead and put up that last slide on how to receive credit. Again, our illustrious Tina will send out an email for you in the next few days that will have a detailed evaluation and ways to claim the credit. Please fill out the evaluation. This is very important to John and myself and to CMSC to hear what your feedback is. Is this something that you're interested in seeing? Again, do we want to continue this in some iteration? And if we're able to get support to do this in the future, we would love to be able to continue these conversations and dive into these studies, whether they're small studies like this or huge meta-analysis studies. We'd love to be able to do this as we move through and try to navigate this virtual world that we're in right now and will be in for the foreseeable future. We really thank everybody for dialing in, for participating, for all the questions, not only tonight, but in the previous nights, and we've just been thrilled and very humbled to be able to share this with you all. And so we thank you, and we bid you a good night.
Thank you. That does conclude today's teleconference and webinar. You may disconnect your line and have a wonderful evening. We thank you for your participation.